Alright gang, today we're just going to be talking about miscellaneous labs, so we're going to be all over the place. Here we go. Throughout this semester, to include today, we're going to be talking about labs used to diagnose specific diseases. So let's just get it out of the way now and review the most common lab techniques used within the medical field. Let's start with the nucleic acid amplification test. These tests have a specificity of 99%. Specificity being the percentage of time the lab is positive that the patient has that specific disease. So if the nucleic acid amplification test is positive, that patient very, very likely has that disease that you're testing for. Sensitivity is a bit lower. Depending on the specific disease being tested for, it can range from about 80 to 90%. Sensitivity is a true negative. So the percentage of time that the lab is negative, that the patient does not have that disease. So let's say sensitivity is 80%. Well then 20% of the time there's going to be a false negative. The nucleic acid amplification test has revolutionized the diagnosis of disease. It is such a fantastic test. There are two common ones: the polymerase chain reaction, or PCR, and the isothermal amplification. They both work through DNA identification and amplification. For example, viruses. Viruses are single-celled microorganisms. They have either RNA, like Zika, dengue, chikungunya, or they have DNA, like herpes. The nucleic acid amplification tests are used to identify the DNA of a specific antigen and amplify it. So it checks for specific antigen presence. With PCR, the sample is collected. That can be blood, swab, tissue, urine, and that sample is heated to uncoil the DNA into two pieces of single-stranded DNA. The sample is then cooled to allow complementary primers to attach to the specific DNA that is being looked for. It then reheats back up to allow DNA polymerase to add DNA bases to the templates. And this duplicates the original DNA sample, creating two strands. It's repeated over and over and over again until there's millions or billions of copies of that specific DNA. Let's do an example. You're testing a patient for the Zika virus. You order a blood test for Zika. It's PCR, so it's a nucleic acid amplification test. Complementary primers specific to the RNA of Zika will be added to that sample. If the RNA of Zika is in that patient's blood sample, then the binding will occur, there'll be amplification, and the copies will be seen. If there's no Zika, there's no binding, and the test will be negative. If the antigen being tested for only has RNA, like the Zika virus, it only has RNA, it doesn't have DNA, well then reverse transcription PCR is used, where the RNA is changed to DNA before the amplification process. If the antigen has DNA, no reverse transcription is needed. Another common type of nucleic acid amplification is the isothermal amplification. No heat is used to denature the DNA, but it utilizes a polymerase with strand displacement activity. So same idea as the PCR. Let's go down to, let's go to the next column actually. Nucleic acid amplification allows for very rapid and early diagnosis of even low levels of antigen. With these tests, once that patient is symptomatic, these tests will pick it up. In some cases, these tests can pick up the antigen before symptoms even occur. That can bring up a disadvantage. It's so specific that a positive result may not equal clinical relevance, because the nucleic acid amplification test can even detect dead organisms. Remember, it's looking for DNA. It also cannot amplify unknown targets. It's not like you take the sample and say, well, let's just do a PCR on it and see what we can find. Specific DNA primers are used, so you're checking for very, very specific antigens. The cost is dependent on the specific antigen being tested for. It can range from $39, which is, say you check someone for chlamydia, you can do a nucleic acid amplification test for chlamydia, it's about $39. Or it can range to several hundreds of dollars for other diseases. Let's go down to immunoassays. These tests are based on the binding that occurs between an antibody and an antigen. I should clarify, when I say antigen, that means any foreign substance that elicits an immune response. So an antigen can be bacteria, virus, parasite, protozoan, a toxin, etc. But this test contains the specific antigen that is being tested for. If the antibody to that antigen is present in sufficient numbers in the patient's body, it will react with the antigen. If there's no antibody present to that specific antigen, then there will be no reaction and the test will be negative. There are two specific ones I'd like to discuss. The rapid antigen test is also an immunoassay, but we're going to focus on the first two. Let's start with ELISA, enzyme-linked immunosorbent assay. It works just as we discussed, but a second antibody, and that second antibody is against the human antibody, is labeled with an enzyme, and once bound, it indicates the presence and amount of the antibody in the patient's sample through a color change that occurs when a substrate is added. Now with ELISA, the results will say IgG and IgM. And those IgG and IgM results are specific to that antigen that is being tested for. Let's go over IgG and IgM real quick. Both are immunoglobulins, and they're produced by B cells. Immunoglobulin M, IgM, is the first antibody to appear in response to the initial exposure to an antigen. It appears within the first week, and then it becomes undetectable weeks to months following that infection. IgG, on the other hand, is the most common antibody found in the blood and the extracellular tissue. And specific IgG, just like specific IgM, binds to specific antigens. But the IgG floats around so that if that specific antigen enters the body again, it is quickly dealt with. Antigen-specific IgG becomes positive after 1 to 3 weeks because the production within the body shifts from IgM to IgG. IgG can stay positive for life. So basically, to dumb it down to its surface, IgG tells you who has had the infection, and IgM tells you who has the infection. For example, you can order IgG and IgM for, let's say, the Epstein-Barr virus, which causes mononucleosis, mono. If someone has mono, generally the IgM doesn't show up until a week after symptoms are present. So let's say someone just gets mono, and the next day you check them for mono. There's a good chance the IgM, it just hasn't seroconverted yet. It's going to show a negative test, even though if the patient has mono. So, and we'll talk about very specific tests and when to order, but specific to mono, generally you give it a week or so before you check the IgM. IgM stays positive for a few weeks and then it becomes undetectable. Meanwhile, IgG to the Epstein-Barr virus will show up a week or so into the infection and it can persist lifelong. So if you order an IgM and an IgG on a patient, the IgM is negative, and the IgG is positive and you gave it enough time, that means the patient doesn't have an acute infection of what you're testing for, but they have had it in the past because they have IgG to that specific antigen. Western blot is another type of immunoassay. The proteins in the blood are separated by electrophoresis. Electrophoresis is using an electric field to separate charged particles. And then those proteins are transferred to a membrane with specific antibodies attached to it. If that blood contains a specific antigen, there's going to be binding with a specific antibody, and then a band or a blot, that's where we get the name Western blot, will be visible. The thickness of the blot corresponds to the amount of antigen present in the sample. So a disadvantage, there needs to be enough antigen present. A patient can have a disease, but the antigen hasn't replicated enough for the Western blot to show positive. For this reason, Western blot is often used as a confirmation test. Once the patient has had a positive initial test, generally Western blot is used to confirm. And let's jump on down there to culture. You just culture the sample and you see what grows. It takes a while. Think of a throat culture. We've probably all had that done. There needs to be a sufficient sample though. So we don't culture a dried up herpes vesicle. It's all dried up and crusty, but you can use a PCR swab because you're checking for DNA, but you cannot culture that dried up old vesicle. It needs to be fresh. The sample needs to be viable because you are checking for active living antigen. Here's a riddle for you. Sir William Osler is thought to be the precursor to Sherlock Holmes. So he has a riddle on hypothyroidism. You'll get the answer in a little bit. Just be thinking about this patient as we go through this. Let's spend some time on the thyroid gland. Let's start with the hypothalamus though. Thyrotropin releasing hormone is synthesized by neurons in the hypothalamus. It's a 242 amino acid protein and it travels through the hypophyseal portal system to the anterior pituitary. Levels of TRH increase as thyroid hormone decreases, and vice versa. So there is a negative feedback loop in play here. TRH stimulates the anterior pituitary to release thyroid stimulating hormone, or TSH. TSH then stimulates the thyroid gland to produce thyroxine, which is T4, and triiodothyronine, which is T3. TSH is secreted throughout life, but it peaks during periods of rapid growth and in response to stress. TSH is inhibited by an increase in T4 and T3, and it's increased in response to low T4 and T3. So there's an inverse relationship between TSH and T4 and T3. TSH is maintained in the body within very narrow limits. But you can see there's this feedback loop in play here. Somatostatin, which is growth hormone inhibiting hormone, is released by the delta cells of the digestive system, but also released by the hypothalamus, and it goes to the anterior pituitary where it inhibits growth hormone TSH and prolactin. So it just helps keep things in check. This just shows you in a healthy individual, TSH stimulates the thyroid gland to release T4 and T3. So it's just trying to jumpstart the thyroid gland if the levels get a little bit low. As a nurse practitioner, you have these labs that are available to you for evaluation of the thyroid system. We're going to go over these, and we're going to go over when you would order which ones, but let's just do some definitions. So TSH is the main one you're going to be using probably in the clinic. It is a sensitive marker of thyroid dysfunction since small changes in free T4 create large changes in TSH, so it's very sensitive. Total T4 and total T3. That measures T4 and T3 that is both bound and unbound. So you could consider ordering these if there is concern of lack of carrier proteins, like if the patient has severe cirrhosis, because in that case, free T4 would be elevated because less would be bound. But otherwise, if the patient has a normal liver function, you're probably not going to be using these too much. Free T4 and free T3, that is unbound T4 and unbound T3, and hence T4 and T3 that is available for use. Bound to T4 and bound T3 is not available to the cells of the body. Free T4 and free T3 are. But free T4 and free T3 act on nearly every cell in the body. Binding activates the increased production of sodium potassium ATPase pumps. This increases the number of pumps and it increases the activity of the cell. So heart rate, hair growth, ventilation rate, basal metabolic rate, digestion, mood, it is all somewhat controlled by free T4 and free T3. T3 is also found in synapses, and it regulates the amount and activity of monoamine neurotransmitters. So pretty much all the metabolic processes of the body are controlled by free T4 and free T3. And then we have the autoantibodies, the thyroid autoantibodies. Anti-TSHR antibody is also known as anti-TSH receptor antibodies. Anti-TG antibody is thyroid globulin antibodies. Thyroid globulin donates tyrosine to combine with iodine to become T4 and T3, so it's just involved in the manufacturing of T4 and T3. And then anti-TPO, anti-thyroid peroxidase antibodies. They are specific for the TPO protein. TPO protein is thyroid peroxidase. It catalyzes iodine oxidation in the thyroid gland. So you're just involved in this manufacturing process. And we're going to talk about when you would order thyroid autoantibodies. And we'll talk about reverse T3 too. I have a whole slide on that. Let's save that one. If you want to start a debate amongst endocrinologists, just ask them what their upper limit of TSH is. You might start a fist fight that way. We know that the lower level is 0.2 to 0.3 milliunits per liter. That's pretty much agreed upon. The high point, the upper limit, so we know TSH is released in a diurnal fashion. We know that TSH levels rise and fall in healthy individuals in response to changes in the concentration of free T4. But individuals have their own set points. Race, age, sex, all contribute to TSH. For example, the elderly have higher normal levels, so the upper limit can be 7 to 8. You can see how the levels differ between men and women from the graph on your right. What does this study show? This was a huge study. It was a study of 6 years. Involved in this study were 16,533 adults across the entire United States and across ethnic groups. These patients were patients who were not known to have a prior thyroid illness, and the mean TSH amongst this group was 1.5 milliunits per liter. So right now, still, the upper limit is about 4 to 5 on most labs. But the mean TSH in healthy adults is 1.5. So the National Academy of Clinical Biochemistry recommends an upper limit of 2.5. The American Association of Clinical Endocrinologists recommends 3. Other endocrinologists and most labs still recommend 4. So as the nurse practitioner, you kind of have to decide what is going to be your upper limit for your patients. They can be anywhere from 2.5 to 8 if you're looking at elderly. If you're looking at non-elderly adults, it can be anywhere from 2.5 to 4. What about T3 and T4? What is this stuff? Well, we know that iodine is essential for a healthy thyroid. Most T4 and T3 are protein bound, so they're not available for use until they become unbound. And T4 is converted into the active T3 in the liver and other organs. T3 is much more biologically active to the cell than T4. But T4 and, to a greater extent, T3 control the metabolism of the body. Let's look at the chemical makeup on the upper right. T4 and T3 are produced and released by the thyroid gland. It's in our neck. Both have 2 iodine atoms on their tyrosine ring. That's their inner ring. Iodine is essential for adequate thyroid function. Notice T4 also has 2 iodine atoms on its phenyl, or its outer ring, while T3 only has 1. That's where we get the name T3, 3 iodine, T4, 4 iodine atoms. Basically, T4 and T3 are tyrosine combined with iodine. So we really need iodine-containing foods, and that's seafood, dairy. Now we can get salt, that is iodized. But a lack of iodine leads to an increase in TRH and an increase in TSH. And that increase in TSH causes the thyroid to enlarge and form a goiter. Another way to get endocrinologists arguing, or not even endocrinologists, family practice as well, is if you are concerned for a thyroid abnormality, do you order the TSH by itself, or do you order the TSH plus the free T4? Unfortunately, just like the upper limit of TSH, I don't have a concrete answer for you, but I do have some studies that may help you guide your own decision and what you want to do with your patients. Let's look at this study here. It involved 4,471 patients. They checked TSH and free T4, and excluded from the studies were those people who had a known thyroid problem. Checking the TSH alone would have missed 3.8%, or 169 people who had a normal TSH but an abnormal free T4. However, of those 169 patients, 144 fell within 2 picomoles per liter of reference range, so that would be consistent with healthy outliers. Therefore, 25 people out of 4,471 would have been missed. So, we'll come back to that, but because of that, the general consensus is check a TSH first, and if it's normal, do no further testing. If the TSH is abnormal, tack on a free T4. The United States Preventive Services Task Force recommends TSH first, then free T4 only if the TSH is out of reference. By the way, when you order a TSH, the lab will hold that blood for 7 days, because so often providers then want to tack on a free T4. So you don't have to call the patient back in and re-stick them, you just call the lab. Also, the European Thyroid Association, the American Thyroid Association, and the American Association of Clinical Endocrinologists all agree on this. But what about those 25 people that would have been missed? Kind of stinks if you're them and your hypothyroidism goes missed. A free T4 is $10. So it's not going to break the bank of most patients. So again, do kind of what you want to do. Some providers, they just order the TSH and the free T4 together. Some providers follow the guidelines of the American Association of Clinical Endocrinologists and order the TSH and then only the free T4 if the TSH is abnormal. You have to decide what you want to do. Now, why don't we check free T3? Free T3 is the biologically active one. Why are we checking free T4? Well, treatment, if the patient is low on thyroid, is synthetic free T4. So checking a serum free T4 provides a baseline to which you can compare to when you start treatment on a patient. Hypothyroidism, high TSH, low free T4. Again, high is subjective. Is that above 2.5? Is that above 4? That's for you to decide which guidelines you want to use. Obviously, if you use 2.5, you're going to have more hypothyroid patients on treatment versus if you use 4, but it's up to you. Is treatment even necessary? Do we need to treat hypothyroidism? Well, if the woman is pregnant, yeah. Remember those complications that can happen to her baby. What if the woman is not pregnant? And I say woman because hypothyroidism is so much more common in women than men. Yes, men can get it, but not nearly as often. Well, what are the pros? Well, the woman will get symptomatic treatment. There will be a decreased risk of cardiovascular disease. There will be decreased risk for infertility. There will be decreased risk for depression, and the list goes on and on. What are the cons? Treatment is lifelong. There's no, unless it's involved with pregnancy, there's really no acute hypothyroidism. This is a chronic lifelong condition. So it requires lifelong treatment. Thankfully, that treatment is extremely cheap, but still, lifelong treatment. Now, there are some blogs out there and some patients who want their reverse T3 checked. Is there ever a role for you as a nurse practitioner to order a reverse T3? Well, this study here followed 7 severely ill people with hypothyroidism. Yes, I admit that's a very low population study, 7 patients, but still. The serum reverse T3 was increased in stepwise fashion with synthetic T4 treatment. Where do we even get this idea of reverse T3? Reverse T3 is produced during severe conditions causing euthyroid sick syndrome. Euthyroid sick syndrome is when the levels of free T3 and free T4 are abnormal, but the thyroid gland appears to be functioning fine. It happens during extreme conditions like starvation or chronic kidney disease where the kidneys aren't barely even working anymore, or severe sepsis. But there is no proof, there are no high-quality studies that reverse T3 can even enter the nucleus. We don't even really know what it does. So yes, it can be elevated during extreme starvation, but generally if you have a patient who is that close to death, there's going to be other things you're looking at versus reverse T3. So for your healthy individual who walks in and says, I'd like my reverse T3 check, say, yeah, save your money. It's not going to change anything. You diagnose your patient with hypothyroidism. You decide to start treatment. What is your goal? Is it symptomatic relief? Well, yeah. Is it a specific TSH? Well, this first study evaluated 52 females, and these 52 females could not distinguish between when their TSH was 0.3 and when it was 2.8. They could tell no difference. The second study evaluated 138 patients. They could tell no difference when their T4 levels were 1.85 or when their T4 was 9.49. So your goal should be treatment to a euthyroid level, meaning a thyroid level that is within normal limits, not necessarily symptomatic relief. So some patients say, oh, I'm still not feeling any better, and they want their thyroid treatment continually cranked up and up and up to the point where it puts them at risk for hyperthyroidism. So your goal should be a euthyroid level of TSH and T4. Let's say you draw a TSH on a patient and it comes back elevated. So then you tack on a free T4 and it's normal. Well, that patient has subclinical hypothyroidism, and you need to decide, do you want to treat it or do you just want to monitor it? Generally, you can wait 1 to 3 months and just recheck it then, unless the patient is pregnant. If she's pregnant, repeat the TSH and free T4 immediately and start therapy if an increase in TSH is confirmed. But if she is not pregnant, you can wait on this if you desire, or you can treat it just like hypothyroidism. The American Academy of Clinical Endocrinologists says you should treat if the TSH is greater than or equal to 10 because it's very likely to progress to overt hypothyroidism. Another option you can do is you can check the TPO antibody. If it's elevated, that patient likely has Hashimoto's, and you would treat it as hypothyroidism. If it's not elevated, you can kind of monitor it. It's entirely up to you and your patient what you want to do with subclinical hypothyroidism. Again, the pros, symptomatic improvement. The cons, lifelong treatment. Central hypothyroidism can be a real bear. It is thyroid deficiency due to a disorder of the pituitary, the hypothalamus, or both. So within that feedback loop, there's a roadblock. Can be a pituitary adenoma compressing the thyrotrophs. Thyrotrophs are endocrine cells in the pituitary that produce TSH. It can be due to abscesses in the pituitary, hemorrhage, stroke. So the first thing you want to do if the free T4 is low and the TSH is normal is just repeat it. Have the patient come back in a week or two and repeat those same labs. If you get the same results, you got to work it up then. First thing, you need to evaluate the anterior pituitary. And that's done with imaging, but it's also done by assessing other hormones that are involved in a feedback loop that involves the anterior pituitary gland. So if the patient is premenopausal woman, you would check an FSH and LH and an estradiol. Postmenopausal, you would check an FSH, and a man, you would check luteinizing hormone and testosterone. You're just looking at other pituitary hormone feedback loop systems. Now, what about prolactin? We know that prolactin is released by the pituitary gland, but prolactin can be increased in both central and primary hypothyroidism, so that's not going to be helpful here. Second thing, we need to evaluate the hypothalamus, but we do that just through imaging of the brain. So all of these patients need imaging of the brain and need to see an endocrinologist. Now, if you see TSH that's normal or free T4 that's low times 2, you can just refer outright. You don't need to bother with any of this, but you can help out your neighborhood endocrinologist by already getting that MRI of the brain and checking these levels so that when the patient sees the endocrinologist doesn't need to start at the baseline. Now, what about if the TSH is mildly elevated and the free T4 is mildly depressed? That could be central hypothyroidism. That could also just be overt Hashimoto's or overt hypothyroidism. Again, you'll want to repeat in about 2 weeks. But this would be a place to check a TPO antibody. If the TPO antibody is elevated, probably Hashimoto's. And you would just treat it as primary overt hypothyroidism. If the TPO is negative, it's probably central hypothyroidism, and you need to go through with the imaging, the hormone lab studies, and the referral. What if the free T4 is low, but the TSH is low too? That can be central hypothyroidism. That can also be subclinical hyper, HYPER thyroidism. In this case, you would want to check the free T3. If it's high or high-end normal, that's subclinical hyperthyroidism. But if the free T3 is normal or low normal, that can be central hypothyroidism. Either way, you need to get endocrinology involved. I think that's my main take-home point here. Central hypothyroidism, consider doing an MRI of the brain, but get endocrinology involved. And that's when the free T4 is low or low normal, but the TSH usually is normal. That is hypothyroidism. Now, I didn't have a slide on it, but you can see euthyroid hyperthyroxanemia and euthyroid hypothyroxanemia. The TSH and the free T4 are generally normal, but the total T4 and the total T3 are abnormal. It's generally not found because total T4 and total T3 are rarely checked, to no detriment of the patient. But other conditions can cause euthyroid hyperthyroxemia, such as hepatitis or steroid use, but there's going to be other signs and symptoms. For example, if the patient has hepatitis, what are the odds that it's going to be diagnosed off of a total T4 or T3? There's going to be other things. So I don't even have a slide on it. You don't have to worry about it for testing or anything like that. It just is out there. Hyper. Free T4 is elevated, TSH is depressed. You can see this with Graves' disease. Graves' disease, most common. Autoimmune antibodies bind to TSH receptors, but instead of attacking them, like in Hashimoto's, they stimulate them. More common in women who smoke. They're twice as likely as women who do not smoke to get this. With thyroid cancer, you can see hyperthyroidism, but it's more common to see a normal TSH and a normal T4. And we'll get to thyroid cancer in a second. You can see it if someone is just taking too much of their thyroid medication. You can see it if someone has thyroid nodules, which again goes along with cancer. You can see it with a molar pregnancy. With a molar pregnancy, there's a non-cancerous tumor of the uterus. This is known as a hydatidiform mole. Molar pregnancy, same thing. But the women appear to be pregnant, but they're not. So they have nausea, vomiting, vaginal bleeding, hypertension. Choriocarcinoma is cancer of the uterus. That's true cancer. There'll be pain, there will be vaginal bleeding. With men, you can see hyperthyroidism with testicular cancer. So both with molar pregnancy, choriocarcinoma, and testicular cancer, there's an increase in human chorionic gonadotropin, HCG. And remember, HCG can bind to TSH receptors. You can see this with pituitary cancer. So the signs and symptoms then are going to be pretty much the opposite of hypothyroidism. The patient may have palpitations. There will be increased cardiac output, so tachycardia, hypertension, congestive heart failure, AFib, cardiomyopathy. With skin, the patient may be sweating or have hyperpigmentation. We'll talk about that with Addison's disease, but an increase in cortisol metabolism increases ACTH, which results in hyperpigmentation. It looks like they went to the tanning booth, but they didn't. The patient may have itching with the eyes, inflammation of the extraocular muscles. You should not be able to see the white sclera under a patient's eyes. I should say iris, not eyes. So if you can see white sclera under the iris, you need to check a TSH and a free T4 elevation. Metabolic, you can see weight loss, hyperglycemia, and that's due to increased stimulation of the beta cells of the pancreas. These patients can be anxious. They can have weight loss and diarrhea, and they can have osteoporosis. So the workup then is to repeat the TSH and free T4, make sure it's consistent with the first results. Then you'll want to ultrasound the thyroid gland to look for nodules, to look for cancer. You'll want to check the thyroid antibodies to get a better idea of what you're dealing with here. Remember, in Graves' disease, they'll likely be elevated. With something with pituitary cancer, they likely would not. And you want to get these patients into endocrinology. Every patient with hyperthyroidism needs to see an endocrinologist. Now, while you're waiting on that referral, if the patient is having the shakes or real anxious, oftentimes a non-cardioselective beta blocker helps. So like propranolol can help with tremors and help with anxiety while they await on the referral to the endocrinologist. Here's a review. Who's this lady? Is this Florence Nightingale? No, Florence Nightingale would shake in her boots if she saw Nancy White Mouse Walker coming her way. She was a New Zealand-born nurse. She joined the French Resistance Special Ops during World War II. She actively battled Nazis. She would parachute as a special ops group in a battle with both guns blazing to free the Allies. A true hero. She was directly involved in battle as a nurse. She was called White Mouse because the Nazis couldn't catch her. She was too silent. She was too sneaky. Okay, you see Nancy White Mouse. She's a 40-year-old female. She's just here for her physical. She feels well. She has some intermittent nausea. It resolves with Tums. She eats a pretty good diet. She gets some sleep. She's a bit stressed. She's starting to use some reading glasses, but she's 40. Who doesn't when they turn 40? She hasn't had a period, though, in 2 months. She hasn't been sexually active for a while. She drinks a little bit. She smokes. She doesn't use drugs. On exam, vitals look pretty good. Her workup looks pretty good. Snellen chart, her vision is not good. You do a pregnancy test. Yeah, she says she hasn't been sexually active. Well, let's be sure. Pregnancy test is negative. I don't see any anemia. I don't see an infection going on. Her platelets look fine. Her electrolytes look just fine. Glucose looks good. Kidneys look fine. Her liver enzymes at the bottom there are mildly elevated. She does drink some alcohol, though. That could be a factor here. I use this example to show where your upper limit can affect a patient. So let's say your upper limit for TSH is 4. Well, 2.3 would need no further workup then. That's well within normal limits. But let's say you use an upper limit of 2.5. Well, now 2.3 is normal, high-end normal. Because it's right on the border there, you would order a free T4. This is also an example of where ordering TSH in addition to free T4 right off the bat may be beneficial. A free T4 is only $10. Because if you use just TSH and you used an upper limit of 4, this diagnosis could go missed. But if you use a lower limit, or you order both at the same time, you would pick this up earlier. And that's what happened. So you would repeat a TSH, you would repeat a free T4, and it comes back nearly the same. Well, what's at play here? If you use an upper limit of 2.5, you're either dealing with overt hypothyroidism or you're dealing with central hypothyroidism. So this is where it may be beneficial to order an anti-TPO. Because in Hashimoto's, the anti-TPO will be positive. In central hypothyroidism, likely it will be negative. And that's what you do, and it's negative. So you are dealing with central hypothyroidism. She has not had a period in 2 months, so that goes along with that. So what is your treatment plan? She's premenopausal. You would tack on, call the lab, be like, hey, I want to tack on an FSH, an LH, and an estradiol, and you need to do an MRI of her brain, looking at the pituitary and looking at the hypothalamus. And there it is, and there's your pituitary adenoma. Okay, please read over this, and we'll go over it in a second. Notice, we're cranking up the dose of levothyroxine. What would you expect to happen to the TSH if you're increasing the dose of levothyroxine? It should go down. That's not the case here. What may be at play? Well, let's go over some things. She's having her medication with breakfast. What is breakfast? Maybe she's taking it with iron. Maybe she's taking it with calcium and it's not getting absorbed. She could be taking it with grapefruit juice, or she could have a malabsorptive disorder like celiac or Helicobacter pylori. She could have Addison's disease, which we'll talk about soon. She could be pregnant. We would want to ask her all about breakfast, what she eats, check H. pylori, work her up for celiac. And this patient actually had celiac. So her levothyroxine wasn't getting absorbed, and we need to get her on a gluten-free diet. Sir William Osler walked into the muggy ward. When the yet-to-be-examined patient was not found in her bed, he asked his medical students, where is the hypothyroid patient? How had he diagnosed her when he hadn't even met her? Well, the bed had many blankets on it, there was hair in clumps on the pillow, and the clothes were suggestive of obesity. There are some inflammatory markers that you as the provider can order. These are blood tests. Now, these are non-specific, so they'll tell you, is there inflammation going on, yes or no? That's it. But that can help you narrow down your differential list sometimes. C-reactive protein, it's a protein found in the blood with a hepatic origin. And it peaks within 48 hours of inflammation and then returns to normal quickly thereafter. So if the patient has an elevated C-reactive protein, likely they're in some acute inflammatory phase. ESR, erythrocyte sedimentation rate, it's the rate at which the red blood cell sinks to the bottom of the vertical tube. So ESR will be measured in millimeters per hour. How quickly are these red blood cells sinking to the bottom of the test tube? When an inflammatory process is present, the high proportion of fibrinogen causes red blood cells to stick together, and they sink faster then because they're heavier. ESR has a much slower elevation rate or prolonged state than C-reactive protein. So with ESR, that patient has been in an inflammatory response probably for quite a while. These are both very cheap tests, so often if you have concern for inflammation, they're ordered together. So you can determine, is this more of an acute inflammatory reaction, or is this one that's probably been going on for a longer period of time? If the C-reactive protein is negative, but the ESR is positive, it's been going on for a long time. If the C-reactive protein is positive, the ESR is negative, this inflammatory state just started. And if they're both positive, it could be either one. These are some options of stool tests you can do. Stool culture, assess for bacterial etiologies. Ovum parasites, that'll look for parasitic infections. It will also check for roundworms, hookworms, tapeworms, flatworms. Ovum parasites are shed intermittently. So a negative test can be a false negative. It's important to do 2 or 3 tests over the week if your suspicions are high. This checks not only for the parasite itself, but for the eggs of the parasite. It's a microscopic exam. Because it's a microscopic exam, though, it won't identify parasites lodged in organs. They must be in the GI tract. They must be passing eggs. Fecal leukocytes assess for white blood cells in the stool. That generally is due to bacteria, but you can see it with inflammatory bowel disease as well, or major inflammatory processes. Rarely will you see inflammation with viral or parasitic infections. So the fecal leukocyte tells you, yeah, there's inflammation here, yes, there's infection here. It doesn't tell you much beyond that. The Shiga toxin assesses for E. coli toxin. Pathogenic E. coli can produce Shiga toxin. It's related to Shigella toxin. So if you're concerned for an E. coli infection, check for the Shiga toxin. E. coli infections cause cramping and watery diarrhea that changes to bloody. For C. diff, if someone's on antibiotics or long-term H2 blocker, proton pump inhibitor, and then they develop diarrhea and abdominal cramping, it's important to rule out C. diff. Generally, C. diff diarrhea isn't bloody. Now, it can be, but that's rare. For C. diff, you can order a direct amplification stool study, but it's quite expensive. And so because of that, generally the glutamate dehydrogenase antigen and the toxin A and B are ordered together. Glutamate dehydrogenase antigen is a stool test. It tests for the protein present in all C. diff infections. It has good sensitivity, it has rapid turnaround time, and it's cheap. It won't test for toxin production, though. Toxin A and B is a stool test, and that does test for the toxins. It has a low sensitivity. And because of that, though, both are ordered. If both are positive, that's C. diff. You don't need to do any further workup. If both are negative, it's not C. diff. If one is positive and one is negative, then consider the stool amplification test to further evaluate for C. diff. It's important to know how to do a fluorescein exam. A fluorescein exam is to evaluate for corneal abrasions and foreign bodies in the eye. So the patient may be working in the shop and feel like they got something in their eye, or they can actually feel something in the eye. Now, of course, you can always refer these patients out to an eye specialist, but it helps if you have this tool in your back pocket and know how to use it. You'll want to dim the lights, and that's because patients who have a corneal abrasion generally are sensitive to light, so the eye will be watering. And if you dim the light, it just makes your job a little bit easier. The fluorescein stain will stain contact lenses, so the patient should ideally take it out. The patient will be laying back. You'll numb the eye up with 1 drop of proparacaine. The brand name for proparacaine is Alkane. It's kept in the fridge. If it's left out at room temperature, it only lasts for 7 days, and it turns cloudy, so make sure it's clear, and that means it's working well. Put 1 drop in the patient's eye, and it numbs it up. Then you're going to take a fluorescein strip, the dye strip, wet the edge of the strip, the orange edge, with 1 drop of saline. And then you're going to draw down the lower lid of the patient's eye and apply the strip to the conjunctiva of the lower lid. Then have the patient blink, move their eyes back and forth. They just want to spread that dye. So just have them close their eyes and move the eyelids back and forth, or the eyeball, just spread that dye. Excuse me. Then the entire cornea, the front part of the eye covering the iris, pupil, and anterior chamber, the entire cornea should now appear green under the blue or black light. And that green light will adhere to any defect in the corneal surface. So you can see there on the right, that green dye is concentrated over the scratch, the corneal abrasion. If you don't see any concentrated greenness, there's no corneal abrasion. And then the greenness also usually outlines any foreign body. And then afterwards, you'll just want to rinse out that dye with normal saline. The potassium hydroxide test is used to detect fungal elements in the skin, hair, and nails. It's a very handy tool in the laboratory. Sometimes it's impossible to detect the difference between a skin infection caused by a bacteria or a fungus. The KOH test will be instrumental if you work in urgent care or family practice. But KOH, which is potassium hydroxide, it's a strong base, and it softens and digests cellular and keratin debris. But the fungal cell wall is resistant to KOH. So a drop of KOH will kill any bacteria, yeast, or other stuff on the slide, but any fungus will remain intact. KOH kills acidic organisms that live in acidic environments. The pH of skin is around 4.7. But this test is not a fail-safe method of detecting fungal infections. It requires a satisfactory skin scraping, appropriate selection of the skin area, and appropriate microscope work. So it does take some practice, but it's not a hard test to perform. Supplies: 2 microscope slides, a cover, a drop of KOH, a lighter, and a microscope. So let's go over what to do. First, take 1 microscope slide and use the side of it to scrape the patient's skin at the area that is most active. The most gnarly looking spot, that's what we want to be scraping. But you'll scrape the dead skin cells and the debris. It doesn't hurt the patient. We're not going deep. It's just like scratching an itch. Just right at the surface, go back and forth with the side of the slide. Don't prep the skin beforehand. Just go straight in. Whatever's on top of the patient's skin that they walk in with, that's what we're going to get. So we're not using alcohol pads or anything like that. Then transfer those scrapings to the middle of the second slide. Put 1 drop of 10% KOH over the scrapings. Put the slide cover over the top. And underneath the slide, so on the opposite side of the skin scrapings, apply a flame for just 1 to 2 seconds. The application of the flame just hastens the destruction of the cellular debris. Don't go longer than a second or 2 because that's going to cause KOH crystals to form. Just 1 to 2 seconds. Then put the slide under the microscope, focus on low power, which is times 10, then scan using high power, which is times 40. You're looking for a fungal hyphae, which you see on the right-hand side there of your slide. It looks like spaghetti and meatballs. If you do this for a toenail or a fingernail, it has to set for a day or 2 within the KOH because that toenail or fingernail is just so hard. But usually we're doing this on skin. You don't have to wait much at all, especially if you use the flame. Okay, that concludes our lecture. Shoot me any questions or concerns. Special shout out to our friends in the lab who help us every day take care of our patients. Thanks, guys.